the 230th session and 462nd case we are having in the PG clinics of in general surgery. I wholeheartedly thank all the faculty who have been supporting all through from the inception. I also warmly thank all the faculty who have kindly permitting their postgraduates and contributing for this program. Thank you very much. Without much ado, then we will request Dr. Monisha to introduce herself, head of the unit and head of the department, and start your presentation, Dr. Monisha. Good luck to you.
Yes, sir. Thank you, sir. Good evening, respected faculties and colleagues present here. I am Dr. Monisha, second year postgraduate from Department of Surgery, All India Institute of Medical Sciences, Rishikesh. I am going to present oral cavity malignancy under the guidance of Professor Amit Gupta, sir, from Department of Surgery, All India Institute of Medical Sciences, Rishikesh. Head of department is Professor Som Prakash Basu, sir. Shall I start, sir?
Yeah, yes, please go on.
My case is a gentleman aged 38 years who's a shopkeeper by occupation running an Ayurvedic pharmacy, resident of Meerut, belonging to lower middle socio-economic class, presented to surgery OPD.
Run your slide.
Your slides. Yeah, move your slides. Okay,
sir,
next
I
one.
have moved, sir.
Maximize it. Keep it on slideshow, Monisha. Can you do it?
Yes, I have.
Can you?
So slideshow I have. Your please. Hello, sir.
Yes, Monisha.
Please. You mute or disconnect the audio. Sir, is the slide visible, sir? Chief complaint slide.
No. We are seeing the introduction slide only with your name.
So I think the cursors might not be working. You have to go and click there, the slide number 2.
With the mouse, you can just click over the second slide.
Sir, I
Monisha, I
have.
will ask you to do something now. You please unshare the screen.
Okay, now it is
Now I
moving.
think you are now okay. Please reshare now.
Mute ಆಗಿದೆ. Sir, is it visible, sir? No.
Wait. On the left side, you have the slide stacks 1, 2, 3. Press on 1 now.
Yes, sir.
You press there, right? When you want to move to the slides, you press the slide number 2, slide number 3 now.
Yes, sir.
Like that you press. That is the only way you will be having seamless presentation.
Yes, sir.
Right?
Okay, sir. Yes, sir.
So you please go ahead with the second slide. You continue your presentation.
Yes, sir.
Good luck.
My case is, thank you, sir. My case is a gentleman aged 38 years, a shopkeeper by occupation, who is a resident of Meerut, belonging to lower middle socio-economic class, presented to surgery OPD with complaint of ulcer over the left side of tongue for the past 1.5 years. Also complaint of left-sided neck swelling for the past 2 months. History of presenting illness. My patient was apparently asymptomatic 1.5 years ago, after which he noticed an ulcer over the left side of tongue, which was insidious in onset, initially small in size, which has gradually progressed to attain the present size. Initially associated with left ear pain, while he developed pain over the ulcer for the past 6 months, which is insidious in onset, usually persists throughout the day, pricking type, aggravated while chewing movements, and relieved on taking oral analgesics. Also associated with foul smelling breath, increased salivation, drooling of saliva, difficulty in protruding the tongue, difficulty in speech, and difficulty in swallowing. There is no history of difficulty in opening the mouth, fever, or pus discharge from the ulcer. History of swelling over the left side of neck for the past 2 months, which is insidious in onset, initially small in size, which has now progressed to attain the present size, not associated with pain or any overlying skin discoloration or pus discharge from the swelling. Also, there is a history of reduced appetite. The patient was initially eating 5 rotis per meal, which has now reduced to 2, associated with weight loss, 10 kgs in 3 months. History of removal of sharp teeth from right lower jaw, right lower molars were removed 2 weeks before. No history of dental caries or loosening of tooth present. There is no history of oral genital sex, multiple unprotected sexual contact, no history of cough with hemoptysis, bony pain, seizures, or jaundice. Past history: the patient initially went to a local hospital in Meerut where he was prescribed mouth pain, which the patient was using for 1 year. Later, after 1 year, the patient self-referred to Ghaziabad private hospital where he was diagnosed to be probable carcinoma tongue, and the patient was referred to AIIMS Rishikesh. In December 2023, the biopsy from the ulcer was taken, later which the patient has lost to follow-up for 2 months. The patient is not a known case of diabetes mellitus, hypertension, COPD, asthma, epilepsy, cardiovascular disease. There is no history of tuberculosis or contact of tuberculosis present in the patient. There is a history of open reduction and internal fixation with plating done 4 years ago in right upper arm for open fracture during a road traffic accident, for which the documents are not available. Personal history: the patient is a mixed diet consumer. The patient has disturbed his sleep patterns for the past 3 months in view of pain. Appetite is reduced, as mentioned before. A patient has also a history of constipation present for 2 years. Patient has history of tobacco chewing for 20 years. The patient used to take 1 packet for 2 days. He used to keep in lower gingival-labial sulcus and spit out before sleep. Patient also has history of pan masala chewing for 20 years. Used to take 10 small packets per day. There is also a history of alcohol consumption, 1 liter per day. Whiskey and country-made alcohol he's taking for 15 years. There is a history of smoking, 4 BDs per day. BD and cigarette he's smoking for past 6 months. There is no history of allergy to food or any medications. Family history: there is no history of similar complaints in the family members. History of liver cancer in his father is present. Treatment history: there is no significant treatment history present in the patient. Summary of my history: a gentleman aged 38 years presented with non-healing ulcer over left side of tongue for 1.5 years, painless to start with and developed pain for the past 6 months, associated with left referred otalgia, halitosis, increased salivation, drooling of saliva, difficulty in speech, dysphagia, reduced appetite and weight loss, and painless gradually progressive left-sided neck swelling for the past 2 months, with a history of tobacco and pan masala chewing for 20 years, alcohol consumption for 15 years, and smoking for 6 months, with a history of dental extraction from right lower jaw with no symptoms suggestive of distant metastasis.
Yeah. Okay, Dr. Monisha. Let's go back to your first slide.
Yes, sir.
I think anyone wants to ask her on history? Invited faculty, please.
Monisha, you are asking history of tuberculosis and contact of tuberculosis. What is the relevance of asking that history here?
Sir, patient has neck swelling, sir. It could be tubercular cervical lymph nodes, sir. To rule out that, I asked, sir.
Okay, Monisha, you said that the patient has difficulty in swallowing. Just next slide, please.
Yes, sir.
Dysphagia. So dysphagia to what? To solids, liquids, both?
Sir, initially the patient had dysphagia to solid food, sir. Now he is having difficulty in swallowing liquid foods also, sir.
So you should say that, right?
Yes, sir. Okay, sir.
That's important. You said
Yes.
there's history of extraction of tooth. Now, did
Yes,
the
sir.
socket heal or not heal?
Sir?
Did the socket heal or not heal?
Yes, sir. Healed, sir.
Is that important to know whether the socket is healed or not healed after extraction of the tooth?
Yes, sir. If malignancy infiltrated, it will be non-healing, sir. Malignant ulcers usually non-healing, sir. Or
Yeah. So if
generally
the bone is involved, usually it will not heal.
yes, sir. Okay, sir.
Okay. So why do you think he underwent remove 3 sharp of right lower when he's got it on the left side? Why were the 3 teeth removed 2 weeks before?
Sir, it was sharp, sir, according to the patient. So it was
No. Sharp means whether the ulcer is on the left side,
Yes, sir.
You're
Ulcer is
removing
on.
3 sharp teeth on the right lower molars. How's that helping? The ulcers on the left side, the molars being, even if they're sharp, you said 3 sharp teeth. How is it relevant?
Sir, it is not significant or relevant, sir, but the patient has
No,
discomfort because of
I
sharp.
disagree. I think it's relevant. I
Okay,
think
sir.
it's relevant. Why do you think it's relevant? And then you said there are no
Sharp-
dental caries or loosening of teeth present.
Yes, sir.
In history, you can't. How can you say that there are no dental caries on history?
Sir, I asked patients are any infection carries for which any root canal treatment was done.
Then why were the 3 teeth removed? There must have been some sort of caries there. It's
Okay,
not for sharp teeth, because the sharp teeth, the ulcers on the left side, isn't it?
yes, sir.
So that ulcer is not because of these 3 teeth,
Yes, sir.
right? So you have to. There's something missing here in your history.
Yes.
Okay. Next slide.
As per Dr. Sahai, why did he ask that teeth are removed on the right side is very relevant. And what could have happened when a patient of CA tongue having an ulcer on the left side and he's having a problem in the right side teeth? What is the cause? Although it is part of the history, but you have written in the history, but what is the cause? Why is that somebody is having ulcer on the left side of the tongue and is having caries on the caries or whatever infected tooth on the right side, which he had to be removed?
Sir, dental sepsis is a risk factor for oral malignancy, sir. So,
That is there. That is there. These are all theory. But the practical thing is that if somebody has a ulcer on the left side of the tongue, then he
yes,
will not able to swallow or do the chewing activity on that side.
yes,
So
sir.
they always use the other side, and that
Yes, sir.
is how the residual food tissue, everything gets stuck there, and
Yes,
which
sir.
can cause caries and infection, for which the tongue teeth got infected. That is why it has to be removed. The other
Okay, sir.
questions are asked very relevant. Was dysphagia to solids or dysphagia to liquids? How a oral malignancy has the dysphagia as compared to a CA esophagus? What is the difference? In both, you will have dysphagia. So there is, because of the CA tongue, whenever
Yes,
you try to swallow, the
yes,
act of swallowing is stopped because because of the inability or mobility restriction of the tongue.
yes,
But
sir.
in a CA esophagus, you will able to swallow, but
Yes,
will not able to deglute or take it inside. So that
yes,
is difficult in swallowing. So that is why he asked very specifically this dysphagia to solids or liquids or to both, because it is the act of the tongue which is being inhibited rather than the actual swallowing problem.
yes, sir. Oral
Okay?
phase affected. Okay, sir.
Yeah, you can continue.
And Monisha,
Yes, sir.
also with this movement of the tongue, which helps in forming the initial bolus for swallowing,
Yes,
was
sir.
there any change in voice? And was his speech affected?
Yes, sir.
Correct.
Patient has a difficulty in speech, sir.
So what kind of speech difficulty does he have?
Uh, Sir, he is not able to produce words. Difficulty in articulation of tongue, sir, due to.
Right. So he's not able to open his mouth completely.
Sir, mouth opening is adequate. So he is not having any difficulty in opening the mouth, sir.
Okay.
But because of
And
difficulty in.
protruding his tongue. So
Yes,
he's
sir.
not
Articulation.
the movement of the tongue is affected now,
Yes, sir.
isn't it?
Yes, sir.
Right. You said about pain in the ears.
Yes, sir.
What is the cause of this pain in the ear? What is this
Sir,
about?
it is referred pain, sir. The lingual nerve is affected, sir, which is referred to auriculotemporal nerve, sir, which is a branch of mandibular division of trigeminal nerve. So the pain has referred to left ear, sir.
So do you think this ulcer has infiltrated deep into the muscles?
Yes, sir. The ulcer was painless initially, sir. For the past 6 months, he is having pain over the ulcer
Okay,
also, sir.
let's come to the other. What are the causes of painful ulcer, pain in the ulcer of this kind?
Sir, painful ulcers would be dental ulcers, sir. Aphthous ulcers, tubercular ulcers, which will be less painful comparatively.
No, I'm asking you what is the cause of a painful ulcer in core-malignant ulcers?
Sir, infiltrating nerve endings, sir. Infiltrating structures which are having pain, nerve endings, sir.
Anything else? Can there be infection?
Yes, sir.
Okay. You said there is drooling of saliva.
Yes, sir.
Okay, why is the drooling of saliva? What are the causes of drooling of saliva?
Sir, a patient has difficulty in swallowing, sir.
So one is
That
swallowing.
causes
Okay.
pooling of saliva and
Any other reason?
sir, facial nerve palsy, sir. Angle of mouth deviation.
Facial. Is there will facial nerve palsy result in excessive drooling here? Excessive salivation.
So not in this case, sir, exactly.
So one is that the patient cannot swallow,
Yes,
right?
sir.
The second
Yes,
is
sir.
that there is excessive salivation also because of
Yes, sir. Because of
irritation.
irritation. Yes, sir.
Irritation of the nerves, right?
Yes, sir.
So they're both the things,
Yes, sir.
right? Okay, you said there is halitosis.
Yes,
Next
sir.
slide, please. Why is there halitosis?
Sir, saliva, infected saliva, sir, that act upon the, that was
Infected
acted upon the
saliva.
bacteria.
Do you think the saliva is infected?
Sir, pooled saliva, sir, acted upon by bacteria.
Okay, why does a person have halitosis?
Sir,
And normal
because of the mercaptans.
we don't. I don't want mercaptans and all, please.
Okay, sir. Okay, sir.
Why does someone have halitosis? If someone has halitosis, what do you tell them person? Go see a dentist. Why?
Sorry, sir.
When a person has halitosis,
Yes, sir.
you tell that patient, go and see a, go and get a dental checkup done. Why?
Sir, dental caries, sir.
Yeah, there caries. There's bacteria growing there, right?
Yes, sir. Yes,
The
sir.
ulcer itself could be fungating,
Yes, yes, sir.
right?
Infected.
Okay. Next slide. Initially small, you can tell. You can ask the patient what was the size. He can tell you it was, say, he can make it to tell you with his finger that this is the size. You can
Yes,
say
sir. My
this
patient measured around 1
centimeter,
cross 1 centimeter.
centimeter, right? You can. I mean, don't leave it vague. Initial small size. It could be a pinhead for all I know,
Yes, sir.
right? Okay. Reduced appetite. Is oral cavity associated with reduced appetite?
Yes, sir. Because of pain, sir, patient can't swallow, or because of halitosis,
Okay,
patient
you
may not
can't
have.
swallow. That is a different thing. I want
Yes, sir.
to. Appetite means I don't want to eat.
Yes, sir.
So is oral cavity cancers associated with?
Sir, not usually, sir.
Yeah,
Unlike
there's very,
other large volume tumors.
it's very unusual.
Yes, sir.
Very unusual. We've gone to
So
this
this is more of fear to pain or because of inability to swallow, they eat less. Not that it is because of loss of appetite.
Okay,
right.
sir.
So it's not appetite. It's a fear that he'll start bleeding.
Yeah.
He'll get pain. He'll not be. He'll choke.
Yes, sir.
That's right.
So
Next.
because not able to swallow, he might have breathing problems. So that is why
Yes.
they fear to eat. Fear to eat is better what than reduced
Okay,
appetite.
okay, sir.
Next slide, please. Orogenital sex. Why we asked for this orogenital sex and multiple protected sexual act? Why?
Sir, to rule out the association with human papilloma virus related cancer, sir.
Which human papillovirus?
Sir, 16 and 18 strains.
Okay, 16, 18, right? Okay, we'll look at HPV later on. No history of cough with hemoptysis. Why do you ask that?
Sir, to rule out any metastasis symptoms, sir, clinically.
So,
Lung metastasis.
any reason for cough with hemoptysis in a patient with oral cancer? They hardly metastasize. They don't metastasize, right? So,
And sir,
what could cause of cough and hemoptysis in a patient with oral cancers?
sir, because of aspiration pneumonitis, patient they can have.
So they can develop lung abscesses,
Yes, sir.
right? Because of dental caries and
Yes, sir.
bone pain. Where bone pain? Where did you ask for bone pain? Everyone has some bone pain sometimes. What kind of bone pain are you looking for?
Sir, back vertebra, sir. Vertebra, sir.
I think she thought of metastasis to brain,
Yes.
bone, and liver. That is why he is written in the sequence.
Look, these are unusual. How many patients of
Oral cancer will have this. Yeah.
This kind they don't. It's not like breast or gallbladder or liver or pancreas, right?
Yes.
They're different. These cancers they're local regional.
Local regional, sir.
They are loco-regional. Visceral metastasis is very rare.
Yes, sir.
Okay.
So I think to complete the history, I think she has mentioned just to complete.
No, but should be aware that this is very uncommon, very rare.
Yes.
Yeah, correct.
Next, please. Hospital in Meerut where he was prescribed mouth pain. Later on, why do you think he was prescribed mouth pain?
Sir, initially the local hospital doctor thought it could be some local documents are not available, sir. What drug?
No. Okay. If someone sees you with an ulcer in the mouth, in the oral cavity, why do people? Why does someone give a mouth paint? Any reason for it?
What is
right?
What is the mouth paint? What does it? You think?
What does it do?
Sir, antifungal, sir. So it provides soothing effect, sir.
Okay, he must have thought that it's probably an upchest ulcer or some ulcers, not malignant ulcer. Not have taken it as malignant ulcer.
Yes,
So mostly they are used. Mostly they are used to counter the pain, actually.
Right.
Yes, sir.
So the biopsy was taken, right?
Yes, sir.
In December 23. What was the biopsy report?
Sir, moderately differentiated squamous cell carcinoma, sir.
So you can say that. You can say that in your
Okay, sir.
If you have a patient and you ask him that whether the biopsy is taken, you can ask him what was the report and can tell you it's malignancy, right?
Yes, sir. Yes, sir.
Okay. What about an ORF 4 years back? Any relevance with that?
Sir, for doing MRI, sir, this patient it will be contraindicated, sir.
Okay.
Monisha, why you will like to do an MRI? Can't you go with the CT scan, or are there some distinct advantages of MRI in this patient where you will like to do an MRI? Suppose there was no plating done.
Indications for MRI in oral cancer.
Sir, a soft tissue delineation is better in MRI, sir. For oropharyngeal cancer, to see the extent of the tumors, MRI is better than CT, sir.
What are the other advantages?
Especially
Sir, bone marrow invasion of mandible, sir.
Especially in CA tongue, because you have a lesion in the soft tissue only.
Sir, adjacent structure involvement like floor of mouth or base of tongue invasion.
Correct.
Okay.
Any special view of CT scan will you like to take for such patients? Where you are dealing with the oral cavity cancers. So what type of CT scan you will request from radiologist? You
Sir,
will ask for puffed cheek CT scanning. Right, Dr.
Okay,
Rudra?
Yeah, correct.
That's for buccal.
Okay.
Another thing I just wanted to that the mouth pain must have been because the patient had leukoplakia or erythroplakia also, right? It could be a cooperative patch. That's why he was giving up. I just
So
wanted
the
to.
another advantage of MRI is that involvement of nerves you can better see on MRI.
Correct.
So
Okay.
neurovascular involvement of the tongue, the depth of the tongue, involvement of the, because the crossover, all that. Okay, so MRI is important. We'll talk about indications for MRI later.
And mostly in oral malignancy, although this is sear tongue, whenever we have RM lesion, anything, retromolar trigon, we always see the muscles, pterygoid muscles, all these. These are better delineated in MRI rather than CT scan. And
Yes.
additionally, to see the mandible status, what will you advise? Is MRI enough, or you want some basic thing to be done?
Sir, for mandible, cortex will be delineated by CT, sir, and marrow will be by MRI.
That's
No, he
okay.
wanted something more
Any
basic than that.
any additional basic thing
Sir,
that is required?
orthopantogram.
Yeah, correct. So, what is a orthopantogram?
Sir, X-ray of mandible with alveolar sockets, dental X-rays.
You're right, but how it is seen? Does it see in a curved manner, or it is a flat one?
Sir,
Have you seen an orthopantogram?
sorry, sir, no, sir.
So it is always a flat one. The mandible is straightened actually. When you
Okay, sir.
see the film, it is completely like a single, not in an arch. It is a single plate
It's just taken
because
in an
it.
arch, but it's put it on a flat piece of
Yeah.
radial plate. Okay. Okay,
So
let's come
that
to your
is,
diagnosis.
yeah.
So
Please continue.
yeah, let's go to your constipation for past 2 years. Okay, pan masala. Okay, let's come to your this pan masala bit. Come next slide. Okay, pan masala. How does it pan masala with alcohol? What is so interesting about it?
Sir, pan masala contains betel nut and lime, sir. The lime causes mucosal trauma, sir, which will be acted upon with the carcinogens like
So
nicotine.
you think the lime is more important than the tobacco?
Sir, betel nut, aricolen, sir, and tannins.
Yeah, they contain tannins, right?
Yes,
So
sir.
that is the betel nut. What
Yes, sir.
about tobacco?
Sir, nicotine, sir.
Okay. So what does that tobacco do? How does nicotine or tobacco cause pregnancy?
Dr. Mayank, you can also ask questions,
Yeah.
please. Yeah.
Okay.
I think
So,
Dr. Subhaya has joined. Good evening, sir. Dr. Subhaya has joined, I think.
yeah, Dr. Monisha, you have presented a very good history. I just wanted to ask like 2-3 questions. Like,
Sure, sir.
tell me about this preferred pain. What is the pathway? I mean, how do you see it? Do you think it's different for different part of tongue, or it's same? Tell me the nerve supply basically of the tongue, which is causing this type of pain.
Sir, a lingual nerve supplying anterior two-third of the tongue, sir. That is referred to auriculotemporal nerve. Both are the same. Both are branches of mandibular division of trigeminal nerve, sir.
Okay, so the efferent is lingual and efferent is auriculotemporal nerve, right?
Yes, sir.
For this case. And what about the posterior tongue?
Sir, glossopharyngeal nerve, sir,
And
and
which is
vagus nerve, sir.
efferent
Auricular vagus nerve, sir.
and tympanic plexus. So
Yes,
the
sir.
pain from the posterior tongue is usually deep-seated pain.
Yes, sir.
However, these pains are you can easily localize to the ear, that is mostly from anterior two-third of the tongue.
Yes, sir.
And other thing is that can you point out few points in your history which suggest that patient is at least having T4A disease?
So
The
T4,
locally
sir.
advanced It's a T4 disease. There are few points in your history that suggest that it's a locally advanced disease. Can you tell me about them?
Sir, patient has difficulty in protruding the tongue, sir, and
So what does
swallowing.
that indicate?
Sir, lingual musculature have been involved, sir, and floor of mouth has been involved, sir.
What are extrinsic muscles of tongue?
Sir, there are 4 muscles, sir: genioglossus, hyoglossus, palatoglossus, styloglossus, sir.
So if they get involved, the tumor itself becomes T4A at least. It's a T4 disease. So it's a locally advanced disease. So
Okay.
other thing is that whenever you are dealing with, like you said, change in voice, so you should talk like difficulty in speech or speaking rather than change in voice, because once you utter the word change in voice, it goes more towards something to do with vocal cords, hoarseness and all. That is typically a change in voice, rather than if patient is not able to speak properly because of tongue movement restriction or pain. So that becomes little different in history. So
Yes, sir.
that is one thing. MRI, I think we will discuss later, but just because it has been mentioned. So MRI is basically the most important thing to see in MRI is 4-5 things which should actually see in tongue is local
Sir,
exchange.
yes, sir, floor of mouth infiltration,
We
perineal
will more
invasions,
say-
or
Okay, so nowadays the most as per AJCC 8 classification which has come now. So what we have is a term called depth of invasion. So what
Yes,
we
sir.
call as DOI.
Yes, sir.
So DOI is actually pathological entity, but
Yes, sir.
MRI gives an idea that what is your depth of invasion. So depth
Yes,
of
sir.
invasion has been incorporated in the staging now.
Yes, sir.
So suppose a tumor is small like 2 centimeter, but still depth of invasion is like 1 centimeter, then it becomes T3
T2.
rather than T2. Okay.
10.
So depth of invasion if increases, the stage goes up. So depth
Yes, sir.
of invasion you have to see in MRI plus neurovascular bundle involvement, perineural invasion,
Yes, sir.
and one more thing that MRI gives you an idea that how much tongue is going to be sacrificed after surgery, so that you can plan your reconstruction accordingly. How much volume you are getting from a free flap or a local flap. So MRI will give you an idea that how much volume is going to be lost. So
Yes, sir.
that's why MRI is very important in tongue cases at least.
Yes, sir.
Okay.
Monisha, is there any role of PET CT scan in this patient? Will you like to request a PET CT for him?
Yes, sir. PET CT we will reserve for inoperable cases for follow-up or to see the responses, sir.
No, but in this patient, what you have history you have presented, is there any indication of PET CT scan or not?
Sir, distant metastasis of oral cancer is rare, sir. CT chest will be enough to see the lung metastasis, sir. PET CT may not be indicated, sir.
But it is still indicated when the nodal burden is very big in the neck and when the lower neck nodes are involved with malignancy, right?
Okay, sir.
In those patients, there is still a role of PET CT scan.
Okay,
Yeah,
sir.
Dr. Rudra, you agree with this, sir?
Yeah, because she's right that in NCCN, it doesn't mention the role of PET CT. It is only the CT chest is enough. But in
Yes.
limited cases where you have a heavy burden disease, where you feel that there is chances of having a distant met, especially in locally advanced with the heavy burden nodes, there sometimes these patients have presented with distant mets, but mostly when you deal with a locoregional disease, CT chest to exclude the lung mets is enough rather than going for PET CT.
Okay.
Yes, sir.
Yeah, Dr. Monisha, I was asking you about tobacco and
Yes, sir, please.
and alcohol. So, Donna, I'll just let you know, tobacco, it affects the DNA methylation,
Okay, sir.
right?
Yes, sir.
Areca nuts contains arecolin and all, which are alkaloids, and they cause dysplasia.
Yes, sir.
While alcohol, it dissolves and spreads the carcinogens all over.
Yes, sir.
So they're
So-
all synergistic.
Synergistic. Yes, sir.
So they are synergistic. Should we move ahead for the examination, sir?
I think we should move ahead because
Please.
Hmm.
Monisha, go ahead with the examination. Okay. Before that, with your history, what conclusion have you made?
Sir, malignant ulcer of non-healing ulcer of tongue, sir. Probably malignant etiology, carcinoma tongue suspecting, sir.
With you got nodes in the neck, swellings in the neck, nothing about that.
Yes, sir. Yes, sir. With cervical lymphadenopathy, sir.
Yeah. So give us the full diagnosis.
Sir, carcinoma tongue involving left lateral border of tongue with bilateral cervical
So
with cervical lymphadenopathy,
you say probably a malignancy,
probably malignancy.
an ulcer, malignant ulcer with involvement of neck nodes.
Neck nodes. Yes, sir.
Those neck nodes could be infective also because the ulcer has got halitosis, could be infective. We don't
Yes.
know they are secondaries, isn't it?
Yes, sir.
So we can't come to it. Right. Okay, examination, please.
Examination, general physical examination. After obtaining consent from the patient and explaining the procedure, the patient was examined in a well-lit room. The patient was conscious, oriented to time, place, and person, comfortable and cooperative. The patient was moderately built and nourished with BMI of 21.8 kg per meter square. Hydration status of the patient is fair. ECOG status is 1 and Karnofsky's performance score is 90. Vitals of the patient is afebrile.
What does those ECOG and Karnofsky mean? Do you understand or just you mug them? What is ECOG status?
Sir, to assess the performance status of the patient, sir.
Correct. So this is a European guideline, and
Yes, sir.
they have a scale. And
Yes,
same
sir.
thing with the performance score. They have got some criteria, and when you add up them, then this score comes. Okay. So
Yes, sir.
you should know details of this. Otherwise, don't just mug up that this is this. You
Yes, sir.
should know why it is used. And when a patient walks into your OPD, you should
Yes.
be able to calculate the ECOG status and the Karnofsky score. Okay.
Yes, sir.
So what do you mean by 90? Karnofsky
Sir, the patient is symptomatic, sir. Mild symptoms, sir, but the patient is able to work, sir.
Look, you're saying he's lost appetite, weight loss, all that kind of thing. What does 90 mean? He's been
So
running out to many hospitals. He's got some debilitation, no? He's not being able to carry out his normal. He's drooling. He can't swallow. Can't be 90,
yes, sir.
isn't it?
Yes, sir.
90 means what? That he's got a. I've got an abscess, and I walk into the thing 90,
Okay, sir.
isn't it?
Okay, sir.
Go on. His BMI is also 21.8.
Yes, sir.
Normal.
Hmm.
Go on.
For the
Next.
So vitals of the patient: temperature is afebrile, pulse rate is 80 beats per minute, regular rhythm, normal volume, blood pressure 128 by 82 millimeter mercury, respiratory rate 14 per minute, saturation 19.
Hang on. Radio femoral delay. When do you get that? When will get a radio delay? When will get a radio femoral delay?
Sir, coarctation of aorta. Will get
Coarctation of
radio.
aorta. Is it? Okay. So when will you get radio and radio femoral, both of them? When will you get radio and when will you get radio femoral?
So if it is post-ductal, we'll get radio femoral, sir.
So what is the relevance of this here in a case of oral cancer? If you get a case in your OPD of oral cancer, do you check for radio and radio
No,
femoral?
sir.
Then
Sorry, sir.
why do you invite trouble?
So
It's all
don't
coming-
write unnecessary things actually, not related.
Unrelated. I've got nothing to do with it. Go on.
Correct.
Go on, Manisha, please.
No pallor, icterus, cyanosis, clubbing, pedal edema, generalized lymphadenopathy, except for cervical lymph nodes are present. Examination of oral cavity. This is the clinical picture. The patient was examined in a sitting position. Inspection. Commissures by both commissures and upper and lower lips were normal. Mouth opening was adequate. 3-finger breath opening was there. There is loss of dentation present. According to the FDA teeth numbering system, the lost teeth are numbered here. The present teeth are numbered here. There is a poor oral hygiene and tobacco staining of teeth present. There is no evidence of dental caries or sharp tooth noted. A solitary ulcer of size 4 × 2 cm, irregular in shape, with everted edges, is seen over left lateral border of tongue, extending 3 cm from tip of tongue anteriorly, base of tongue posteriorly, 1 cm from midline of tongue medially, and floor of mouth inferiorly. There is no active pus discharge or bleeding from the ulcer noted. Restriction of movements of tongue noted. Gingivolabial sulcus, gingivobuccal sulcus, and buccal mucosa normal. Hot palate normal. Retromolar trigo normal. Palpation, there is no local rise of temperature noted, mild tenderness present. Inspectory findings of size, shape, and extent were confirmed. A solitary ulcer of size around 4 × 2 cm was palpated along the left border of tongue, irregular in shape with raised everted edges and pale granulation tissue on floor, extending till base of tongue and floor of mouth. Induration crossing midline present. It doesn't bleed on touch. Retromolar trigo not involved. No mandibular thickening or irregularity noted. Examination of neck. A conglomerated fixed non-tender swelling of size around 4 × 6 cm was palpated over left side of neck, extending from just below the body of mandible superiorly, 3 cm above left clavicle inferiorly, till midline anteriorly and left mastoid process posteriorly, with lobulated surface and variable inconsistency, firm to hard, level 1 to 5 lymph nodes. No dilated veins, sinus or fistula noted over the swelling. Right level 2 lymph node of size 1 × 1 cm was palpated, which is non-mobile, non-tender, round in shape, and hard in consistency. Examination of cranial nerves 9, 10, 11, and 12. There were no involvement noted. This is the clinical photograph showing the neck swelling of the patient. Systemic examination unremarkable. Summary of my patient. A gentleman aged 38 years presented with non-healing ulcer over left side of tongue for 1.5 years, painless to start with and developed pain for the past 6 months, associated with left referred otalgia, halitosis, increased salivation, drooling of saliva, difficulty in speech, dysphagia, reduced appetite and weight loss, and painless gradually progressive left-sided neck swelling for 2 months, with history of tobacco and pan masala chewing for 20 years, alcohol consumption for 15 years, and smoking for 6 months, with history of dental extraction from right lower jaw, with no symptoms suggestive of distant metastasis. On examination, a solitary ulcer of size around 4 × 2 cm along left lateral border of tongue, irregular in shape, with raised everted edges and pale granulation tissue on the floor, extending till base of tongue and floor of mouth, induration crossing midline, with bilateral cervical lymphadenopathy, with no involvement of 9, 10, and 11, 12 cranial nerves noted.
Okay, let's go to your examination. We'll come to this later. No, yeah, next slide. Okay, first thing you have to note is whether there is halitosis present or not.
Okay, sir.
You have to mention in your examination
Yes, sir.
whether there's pooling of saliva or not, whether there's drooling of saliva, all this has to be, right?
Yes, sir.
Next slide.
Dr.
Please.
Can I ask a question?
Yeah, please, sir.
Yeah. So tell me, go to your previous slide. Tell me about mouth opening. What is the importance of mouth opening? What are the causes of restricted mouth opening?
Sir, if the pathology has involved TMJ joint, sir, or because of oral submucosal fibrosis, also patient can have inadequate mouth opening, sir.
It is either joint involvement or soft tissue involvement, both.
Yes, sir.
Right?
So
Yes,
how do you measure it? You have said like 2 fingers, 3 fingers. Do you think any more standard terminology to tell about mouth opening?
Yes, sir. We can grade the trismus. Sir, adequate mouth opening should be inter-incisor distance more than or equal to 35 mm in a edentulous patient, sir.
Yeah, so you should mention actually that what is the inter-incisor distance rather than just saying that 3 fingers, 2 fingers, because
Yes,
you can easily measure it and anybody can relate to it, right? And
Okay,
how
sir.
does it change your approach to the patient? Suppose there is restricted mouth opening, and is it going to change anything, or mouth opening is adequate? Is it going to change anything in your approach to the patient?
Sir, if the mouth opening is restricted, we'll go for radiotherapy, sir, instead of upfront surgery.
First of all, you will not be able to examine the oral cavity, no? If the mouth opening is inadequate. You can't see what's inside.
Yes, sir.
So
Examination
how
will
will
be
you examine? Then how will you examine?
Examination itself
under
is
anesthesia,
difficult.
sir.
Either anesthesia or use a fiber optic.
Yes, sir.
Another thing is, suppose it's an operable case, your approach will change. So suppose it's a restricted mouth opening, you can't do a per-oral surgery. You may have
Yes, sir.
to do a mandibulectomy or a full-through procedure to remove the lesion. So that also is an important thing to know before you proceed for surgery. Plus,
And if
check
there is a
your-
sudden question, never get frightened and commit a wrong sentence. What you told now that because of mouth opening restriction, we will not do surgery and do radiotherapy is a completely wrong sentence. Never,
Okay.
if you don't know, just keep silent. Then the
Okay, sir.
examiner will give some clues, but don't go to a wrong line
Yes.
where you will get negative marks actually.
Just
Okay.
RT. If mouth openings are inadequate, you go for RT. He'll send you home here in the exam. Okay? Don't do that. Okay, you said poor oral hygiene and then no dental caries. So what hygiene are you looking for?
Sir,
If there is halitosis and there's poor oral hygiene, there's got to be something else. There's got to be caries.
okay, sir.
You may not be able to spot it because you're not a trained dentist, but a dentist. So the best way to find out is you ask them whether they get any cold or warm sensation with rings.
Okay, sir.
That's the best way to find out. Okay, next slide,
Yeah, a couple of questions from my side.
please.
Is the mouth opening restriction is because of TA, temporomandibular joint, or muscles acting on the joint?
Sir, muscles, sir.
You mentioned the temporomandibular joint. It is muscles acting on the joint. What are the muscles that cause trismus?
Sir, muscle, the muscle which is responsible for mouth opening will
No,
be
literally.
lateral pterygoid.
Can you enumerate the reasons
Yes, sir,
for
lateral
trismus?
pterygoid.
No, can you enumerate the reasons for trismus in oral cancer?
Sir, pterygoid muscle involvement, sir. Pterygoid space involved.
Which pterygoid?
Sir, lateral pterygoid.
Okay. What's the action of lateral pterygoid?
Sir, it protrudes the mandible, sir. And
Opening the
depresses
mouth,
mandible,
opening of the
opening the
opening,
mouth and side to side movements.
no, opening of the mouth or closure of the mouth?
Opening of the mouth, sir.
Then mouth should open. If the muscle is involved, it will go for contracture. If it gives the contracture, the mouth should open. Should not close.
Which is the only muscle? Which are the muscles which help in bringing out the mandible up? It's closing the mouth.
Sir, temporalis, masseter.
Masseter.
Middle.
Masseter is the one.
Okay, sir.
Okay, next slide, please. Okay, what about movement of the tongue?
Sir, it is
Okay,
restricted,
what
sir.
movement of the tongue is restricted? Can the patient protrude the tongue out or not?
No, sir.
So you say that the restricted movement of the tongue, what? Up, down, outside, inside, lateral movements. Which movements?
Sir,
Right.
generally all movements are restricted, sir. Patient can't protrude the tongue also, sir.
Okay, which muscle is involved in protrusion of the tongue?
Sir, genioglossus.
That's the only muscle. All other muscles are foreign. So you should say, now, the tongue could not be protruded even at all, or a bit, it was restricted. Was there no protrusion, or was there a restriction?
Sir, he couldn't protrude out of the mouth, sir. Out of oral cavity, he couldn't protrude, sir.
So when he tried to protrude the tongue out, was there any deviation of the tongue to one side?
No, sir.
So all that has to be mentioned.
Since it is restricted, I was having doubt whether to mention deviation of tip
You
of
have to
tongue.
mention that there's he's थोड़ा बहुत तो निकलता ही होगा. It couldn't be that there's absolutely stuck inside it. With this kind of ulcer, I don't expect it to be absolutely stuck inside the mouth.
Okay, sir.
Okay, Dr. Monisha,
Yes, sir.
what is the importance of midline? You said crossing midline. In tongue cancer, why this midline is so important? Do you think how it's going to affect your management?
Yes, sir. The patient will be going for total glossectomy, sir. If
So
midline
anything just
Anything
crossing
else?
the midline, you will do total glossectomy. It's a very morbid procedure.
Okay, sir.
So
Sir, a
Anything else?
biometric note should be addressed.
I again say, whenever a question is asked, don't frighten and tell wrong sentences, because that makes things negative. Now, he has asked a very pertinent question, that when it crosses the midline, what is the importance? And if it is not crossing the midline, what is the importance? There are very simple answers.
Monisha, your whole management changes, no? If it is crossing midline.
What is
So
the
what
lymphatic drainage of the tongue?
Sorry, sir.
What is the lymphatic drainage of the tongue?
Sir, level 1, 2, 3, sir. Bilateral neck should be addressed in surgery, sir.
So if it's a crossing midline, then one is the extent of surgery, local excision will change.
Okay,
And
sir.
but it won't be like total glossectomy always. In some
Okay.
cases it may. Other thing is, suppose a lesion is crossing a midline, but opposite side you can't palpate any node. But still you have to sample that side, what we call as SMLND, selective neck dissection.
Neck dissection.
Right.
Of the
You'll have to do
contralateral. Of the contralateral. That is why
Contralateral.
Dr. Saya asked, what is the lymphatic drainage? When it is crossing midline means it is affecting both side lymphatics.
Yes, sir.
Also for the tongue, because it's constantly moving, it's got this action to press onto the vessels, and there can be embolization of malignant cells through the vessels
Okay,
and
sir.
the lymphatics. So crossing midline makes the other side also very vulnerable.
Okay, sir.
Okay. Did you see? You said there was pain in the ear. Did you examine the ear? You've not examined the ear. Not told us anything about the ear. You presuming that it's a what, pain from the oral cavity.
Sorry, sir, I didn't examine, sir.
Why? You shouldn't you? Suppose the pain would be just because of that or something, or there could be discharge from the ear, right?
Yes, sir. It should be addressed, sir.
You should.
Always.
Yes, sir.
Right? And if you can't,
Another point is, whenever it is crossing midline, you will always need some kind of free flap for reconstruction. It cannot be managed from the primary rotation of the tongue during the reconstruction. So it is very important from the beginning in the surgical planning also, whether the ulcer is crossing the midline, then you will need some kind of free flap to recon. Otherwise, normally on a single unilateral lateral border, you can make rotate the tongue and reconstruct the tongue directly from the tongue tissue only. So these are part of the surgical planning that is important when you are crossing midline. How do you examine the fixation of the tongue to the floor of the mouth? How do you examine?
Sir, floor of mouth involvement can be by bimanual examination, sir.
By manual or by digital? It's
By
by
digital.
digital. Yeah, right.
What is bimanual and what is by digital? Again, you only told this, so I'm asking.
Sir, bimanual
Where
using both hands.
where you do a bimanual? Just I want examples. Where you do a bimanual and what is by digital? Here by digital is correct, but where you do bimanual?
In parotid swelling, sir.
Very simple is kidney.
Okay, sir.
So whenever you have a lung swelling or a kidney swelling, you always do the bimanual from back and front. You do the with both the hands. But here you are only doing the restriction of the tongue movement. So we will do a bidigital examination.
Yes.
Okay, by examination, could you find out whether the intrinsic muscles of the tongue are involved or the extrinsic? Can you find out whether the extrinsic muscles of the tongue are involved or the intrinsic muscles are involved or both are involved? How will you examine to find out?
Sir, for extrinsic muscle, we'll ask him to perform the concerned movement, sir.
Very good. Very nice.
Protrusion.
What about intrinsic
touching
muscles?
hot palate, sir.
What about intrinsic muscles?
Sir, intrinsic muscle making the broader, narrower
Change in shape of the tongue?
shape, yes,
Yeah,
sir.
correct.
Right.
Yeah, very
That
nice.
is
Very nice. Very
Can't
nice.
you palpate extrinsic muscles digitally?
Genioglossus.
Can you palpate? That is what Sir is asking.
Genioglossus, higher glossus, can you palpate digitally? If you put your finger in one side of the tongue and the other finger the opposite neck in the submandibular region, what are all the intervening structures you will palpate? Got my point? You put one finger underneath the tongue on
Yes,
one
sir.
side.
Do you
Inside
know how the
mouth.
muscles are placed? How is the extrinsic muscle placed and how the intrinsic muscle is placed? That will give you a clue to answer.
Okay, Monisha, before we move ahead, I have a
So
quick
extrinsic
question.
muscles here. Right, so please, sorry. Go on.
Sorry. So when do you decide to do I want to do EUA in examination under anesthesia? Do you always do it, or you see a patient, examine and say, no, I need to do EUA?
Sir, if the patient having difficult mouth opening or the ulcer is more posteriorly placed, not accessible for examination or biopsy, in those conditions we'll go for.
So what? How? Suppose there is a 2 into 2 centimeter ulcer. It's not a big ulcer, but it's towards the posterior tongue. So what makes you think that I should do EUA? What part of the ulcer? Yeah.
The examination of anesthesia is to when there is pain or when there is restricted movement. Do you think mouth opening will be improving under anesthesia?
No, sir.
Actually, whenever
Having
patient
pain
is
and
having
not allowing for examination.
whenever patient is having pain, that precludes effective examination. You can alleviate pain by giving anesthesia and examine. That's the purpose of examination anesthesia. And the muscle spasm will be less. Because muscle spasm induced by pain will not be there under anesthesia. That's all. If
Yes.
the direct involvement of muscle, then I don't think mouth
I
opening.
think Moink is talking about base of tongue involvement.
Yeah.
And it is going to the tonsils, or then you have to see the extent of involvement. Right, Mayank?
Yeah, so in simpler terms, I mean to say that whenever you can't see or feel the posterior extent of the lesion or ulcer properly,
Correct.
you
Correct.
don't know how much posterior it is. So that is one point. And of course, if patient is resectable, it's not like the patient is unresectable and you are going to do a EUA for no benefit. So if you are planning a surgery and you feel that you don't know the posterior aspect of the lesion, then you plan EUA, basically.
Okay, sir.
Means
Just one very simple question. Let us say if you see a ulcer on the anterior 1/3 of the lateral part of the tongue, do you need to do a complete palpable examination of the complete tongue, or you see the visual part and just according to that you plan the things? What is the significance of doing a wearing a gloves and making the proper complete palpation of the tongue from the normal side to the affected side, starting from anterior tip to the complete posterior base of tongue? What is the importance?
Sir, one thing we should see the extent of the tumor, sir, and second thing, field cancerization is common, sir. So to look for any other
So,
secondary primary is there.
correct. So multicentric presentation. Sometimes because of the field cancer, we have always, sometimes people have done treatment to the anterior part and they have missed a base of tongue tumor which is synchronously already present because of field cancerization. So always whenever you do a examination, do a complete palpation of the whole tongue, starting from tip to the posterior, lateral border to lateral border, and if required, if you have any doubt, then ask for a examination under anesthesia. You can continue next.
Okay, now let's come to your description of your ulcer. It's an irregular shape, size, pivoted edges seen over the lateral border, resting 3 centimeters on tip. Base of the tongue. One second, okay. What about the margin, the edge, and the base of the ulcer, and the floor of the ulcer? Have you not described them?
Yes, sir. The floor of ulcer, no slough noted, sir. Pale granulation tissue was there.
Right. And what were the margin?
Not
Is it-
erythematous, sir.
Is it everted? You said margin
It
is
is everted, sir.
edge is everted. And what were the margin?
Margin not erythematous, sir.
Okay.
On inspection.
Next slide. Okay. Let's come to your palpation. Next slide. Local rise of temperature is not important here. You think there will be local rise of temperature? It's an abscess.
Any
Why are you looking
infected?
for? So if there's infection in the tongue, the temperature of the tongue will rise.
No, sir.
Then, I mean, it's don't I think all residents do this. They carry this extension of inflammation to local rise of temperature in all cases. Just you're going to be a surgeon. Just use your good sense. Okay, solitary also seen around palpated left, irregular shape, raised, everted, pale granulation tissue on floor, extending into the base of and the floor of the mouth. Okay.
Yes.
Okay. Why is the floor of the mouth so commonly affected? How's the floor of the mouth affected if there's an ulcer in the tongue?
Sir, saliva is pooling, sir. Carcinogens, it will be exposed to carcinogens.
Yeah, that's carcinogens also, and melanins also. So it's carcinogens which is pooling around, and usually the floor of the mouth has got the mucosa is very thin, and they get affected very easily.
Okay,
Induration crossing the midline, retromolar knot. Palpations. How do you go for retromolar trigon knot involved? How will palpation help you?
So there were no induration noted, sir.
What is RTM? It's a bony structure, na? With mucosa over it. You can say the mucosa is mobile over it, but that's hardly, it's not a
Mucosa.
palpatory line. If the patient can't open the mouth completely, then we can think of RTM involvement.
Okay, sir.
Mandibular thickening and irregularity. Why did you note that?
So to look for mandibular involvement, sir. It will upstage the disease, sir.
Okay. And you didn't mention about the missing teeth socket. Are they healed?
Yes, sir.
Right.
No ulcer.
That's important to tell. Okay, involvement of which tooth is very important in oral cavity cancers? And why? It is the
Sorry, sir.
canines. It's the canines. Because they have the deepest root. So if a
Okay, sir.
canine is involved or it drops out, the chances of the alveolar, the mandibular canal is very high.
Okay, sir.
It's the same thing with edentulous teeth. So the teeth have been removed, the sockets are exposed, and the chances of involvement of the mandibular canal is very high. Why is that important? Involvement in the mandibular canal?
Sir, again, it will upstage, sir, and the management will change, sir.
Right. So you'll have to go for a segmental rather than a marginal resection.
Marginal.
You have to do something on the mandible. Okay, next slide. Conglomerated. What is this conglomerated fixed non-tender? What do you mean conglomerated?
Sir, multiple swellings mated lymph nodes were palpated, sir.
So they're matted.
Yes, sir.
Why does matting? What is matting? Why does matting happen?
Sir, capsule, invading into capsule and they...
Yeah, if the capsules are involved, usually happens in inflammation, but can happen in malignancy also when the capsule is breached.
Okay, sir.
So that means that there's extranodular extension. Can be extranodular extensions.
Okay, sir.
Okay, which lymph nodes are important? You said lymph node 1 to 5. What is this lymph node number in Roman 1 to 5? Numerical 1 to 5? It's only Roman letters, isn't it?
Yes, sir. Sorry, sir.
Yeah. So what is this 1 to 5? You mean the submental is also involved?
Yes, sir.
Okay. So why is the submental involved? What's the drainage of submental?
Sir, chin, lower lip, tip of the tongue, anterior tongue.
So there's something else. So there is involvement beyond what we have palpated, isn't it?
Sir.
Okay, cranial of 9, 10, 11, 12. How did you examine them? 9, 10, 11, 12.
Sir, for 9, 10, uvula was not deviated, sir. There is...
What is it?
Uvula in midline, sir.
Uvula midline. Okay. Then? 10?
Sir, symmetrical palatal movements were there, sir, for gag reflex. Sir, for 11, shrugging shoulder against resistance and turning the head towards the contralateral side against resistance were present, sir.
And 12?
Sir, and for 12, there was no wasting of the tongue muscles noted, sir. A dip of tongue was not deviated, sir. On minimal protrusion possible, it was not deviated, sir.
So, please carry on. Okay. So, what's your staging? Clinical staging T3. What do you mean by T3?
Sir, the size of the swelling in the greatest dimension is more than 4 centimeters, sir, and depth of invasion is more than 10 mm or more than 10 mm, sir.
Depth you can't make out here.
Yes, sir, but
difficult.
Size in greatest dimension.
Okay.
More
Okay.
than equal.
Okay. So now, how will you go about managing this patient?
Sir, regarding investigation to confirm my diagnosis, for a primary tumor, I'll do punch biopsy from the ulcer, sir. And regarding the neck swelling, I'll do USG guided FNAC from the neck swelling, sir. Regarding staging of the disease, we can do CCT head and neck, sir. MRI we can do so, but this is contraindicated in this patient, sir. Metastatic workup, C3 chest, sir, and for baseline investigations for a preoperative or pre-chemotherapy radiotherapy, sir.
So why will you take a punch biopsy and not a wedge biopsy?
Sir, oral tongue cancers are notorious for invasion, sir. So we need more deep and narrower ulcer rather than shallow, broad ulcer, sir.
So you think a wedge biopsy would be shallow? Okay, from which part of the tongue will you take this biopsy?
Sir, anterior, sir, more accessible part of the ulcer will take, sir. Anterior part of ulcer.
One posterior.
The answer. What is the exact answer to this question?
Sir, from the edge, including the normal mucosa, sir.
Yes, correct.
Okay. So
why don't you take from the middle? Why you
sir,
take
more of
from the
necrotic.
more of necrosis? Correct.
okay, so you've got a moderately your biopsy commands moderately differentiated
Yes, sir.
squamous cell carcinoma. Okay. Right. And what about the lymph node?
Sir, USG guided FNAC we will do, sir.
What
No,
does
have
it?
you got it?
Have you done it?
No, sir, not it, sir.
Okay.
Suppose you've done it and it come out as poor infective.
Sir, it may not be from the representative section, sir. Geographic metastasis, mismetastasis is possible, sir. So still we will go for bilateral, we'll address bilateral neck nodes, sir.
Dr. Monisha, in such an advanced case where you have bilateral necks which are matted,
Yes, sir.
and why do you want to FNA? Do you think it can be anything else? You have already a diagnosis from tongue that it's a moderately differentiated squamous cell CA.
Yes, sir.
And this patient which has such a big node which is matted, there is extranodal extension. Are you going to give any benefit to the patient by is it going to change your management anyway?
No,
Are you
sir.
expecting anything else?
No,
So
sir.
in such cases, clinically you may not need to do any FNA for nodes,
Yes,
at
sir.
least, because it is definitely clinically positive nodes.
Yes, sir.
You are not going to change it other way, because sometimes what happens, these nodes are so big matted that they are cystic.
Yes, sir.
Necrosis, you do a FNA, it comes necrosis only. You will keep on chasing up, unlikely that it's going to change your management.
Yes, sir.
So you may skip, at least in this patient, any USG guided FNA or biopsy of the nodes.
Actually, if the node should be assessed histopathologically, cytologically, only when you have doubt.
Okay, sir.
When you don't have any doubt about involvement, here there is no doubt, you know.
Yes, sir.
When you are in doubt, you can do FNAC. Like in cancer breast, you have a suspicious node. Whether you want to have sentinel node or not, you want to cytologically prove it is negative. In that scenario, you can do.
Yes, sir.
Here, anyhow, it's apparent that even whatever the result of FNAC or even true cut biopsy, you can do. What is that? It is nodes are such a big. Even true cut biopsy, if you can do, if your primary biopsy repeatedly fails because of extensive involvement, and you don't have a facility to give anesthesia, or anesthetists are little afraid, or patient is not fit for anesthesia because of aspiration, pneumonia, this and that, then you can do true cut biopsy and prove the malignancy. Otherwise, you need not to go for evaluation of neck cytologically or histopathologically.
Okay, sir.
Okay, for your investigation, you said CT scan. There was a talk about PET scan.
Yes, sir.
So when do you want to do a PET scan?
Sir, if there is a high burden of the disease as mentioned earlier, sir,
High burden of
to assess the response, sir.
what do you mean by high burden? It is when you're going to give some adjuvant therapy like or to planning of radiotherapy,
Okay, sir.
right? Then we will like to get a PET CT. Otherwise, PET CT has got very little role.
Okay, sir.
Okay.
So what extra information a PET is going to provide you? So in this patient, what extra information you are going to get from PET?
Sir, any other Mr. Distant metastasis? Or,
That you can get from CT thorax,
yes, sir.
or if you are thinking of some unusual sites of METs. What I mean to say, suppose the patient is having a lesion which looks curative or looks operable, but suppose he is having bone pain. He's saying that I have a severe backache since last 1 month, 15 days. Then you can think of an investigation which may give you more information. Okay, like there are few sites where PET scan can be of more use than CT scan. Okay, so that may be one. And see, in current era where we have immunotherapy, not for head neck cancer, but many of the cancers where we follow them with PET scan. PET scan is one.
You need a
thing is
baseline PET scan, right? You need a baseline PET scan.
So it's not readily available and it's a costly thing. So you should always think twice before subjecting a patient to PET scan.
Okay, sir.
Okay. Yeah.
Okay. So now how will you manage this patient?
Sir, we will discuss that case in multidisciplinary tumor board discussion, sir. After that, we can go for a neoadjuvant chemotherapy. So we will improve the oral hygiene of the patient and nutritional status of the patient, sir. Then we can go for neoadjuvant chemoradiotherapy, sir, before upfront surgery.
Neoadjuvant chemoradiotherapy. That is. So this patient.
Sir, chemotherapy for radiosensitivity, sir.
Again, I'm advising you the same thing. Don't utter unnecessary words to create trouble for yourself.
Sir, would you like to give chemotherapy or you will like to give only neoadjuvant radiation?
Okay, sir. Sir, I meant to say that cisplatin as a radiosensitizer.
No, why do you want to give chemo? Okay, let's come to that. Why do you want to give chemo? This is squamous cell, isn't it?
Yes, sir.
Right? It's involved with the tongue and nowhere else.
Sorry, sir.
It's involving the tongue and nowhere else.
Yes, sir. Tongues.
And the lymph nodes. So radiotherapy is an adjunct to surgery. It is used for local management.
Yes, sir.
So you can give up an upfront radiotherapy, get it down the downside so they can manage, do a surgery and go ahead. You can do it the other way also, but that we've got oncosurgeons here. Let them give you.
I think there is a clear-cut guidelines. Let us not confuse.
Please.
Manisha, now finally, what do you think is in what stage this tumor, this tongue is in which stage, and what is the clinical TNM? First you mention.
Sir, T3, sir. M0, sir, clinically.
N0, you told you palpated the nodes.
N2C, sir. N2C, sir.
Why did you say N2C?
Extracapsular disease will alter the stage. Extracapsular disease, matting, it will alter the stage.
Yes, sir. N3B, sir.
Okay, then the tongue is not at all moving. What do you think? The depth of involvement will be less than 1 centimeter, is it? Here, the size is more than
Whenever
4 centimeters.
the size is more than 4 centimeter, the tongue movement is restricted. So I think what Mayank sir told, depth of invasion, which is from the beginning, so will be high. So what will be your
So T4A, N3B, M0, sir.
Mayank, do you agree?
Yeah, sir. I mean,
I think I agree. T4A, N3B, and M0. So in such a scenario, what will be your management, or in a multidisciplinary team, you are
What is the stage
are-
grouping?
stage grouping important.
Sir, 4B, sir.
4B, is it curable?
No, sir.
so
M0, na?
Yes,
You
sir.
told M0.
M0, sir.
So T4A, N3B, what is the stage grouping?
Sir, 4B, sir. Stage 4B.
Yeah, for me.
Mayank,
yeah, it will be 4. But tell me how it. You said it's an NART. So I will just tell you one very basic principle of oncology. When
Yeah.
do you give neoadjuvant therapy? What do you think about neoadjuvant therapy?
Sir, if the tumor is inoperable, sir, then we can go for
inoperable, so it will be inoperable will be always inoperable. It's not inoperable.
You can operate you can remove the thing, but the thing is that you can have results and reconstruction will also be an issue. Take the whole thing.
Neoadjuvant means you are giving before a definitive treatment, right?
yes, sir.
So definitive treatment is always in your mind that I will either operate or give definitive radiation. So it's not inoperable. You can say it's locally advanced.
Local
Plus,
advanced.
again, what is the philosophy of the neoadjuvant chemotherapy? I will just tell you in short that one is that if you are suspecting that there is some sort of micrometastasis or systemic disease which you are going to deal with,
Okay, sir.
like in locally advanced cancer, node positive cancer. Secondly, there are certain sites which respond to chemotherapy, like they are known to respond to chemotherapy, like breast. But head neck cancer, they are not known for responding well to chemotherapy or radiation, right?
Yes,
So
sir.
in head neck cancer, the best possible treatment whenever possible is surgery, without doubt. When you are doubt, then you start thinking about giving all sort of neoadjuvant or radiation. So, plus in this patient, if you give radiation before surgery surgery, and if you are planning NART, that means you are saying that I will give chemotherapy, radiation, and then I will operate. That will become very complicated because radiation itself will cause so much of change that surgery will probably become impossible for this patient. This patient unlikely to undergo surgery because bilateral node. But the only chance you can have is to give probably NACT, neoadjuvant chemotherapy, and see how well he responds. So there will be around, I think there is only 10 to 20% chance that he will respond to chemotherapy. And then you may plan a surgery, but prognosis will still be bad, right?
Okay, sir.
So NART is not probably an option as per guidelines, but you can think of giving neoadjuvant chemotherapy some sort, and then reassess him after neoadjuvant chemotherapy and see if you can do a surgery, right?
Okay, sir.
so first thing is you must first define whether you are approaching the patient with a curative intent or a palliative intent. Your
How will you decide whether the patient can cure or requires palliation?
Yeah. So if you are having a curative intent, definitely always you try to give neoadjuvant. As Mayank told, neoadjuvant induction, neoadjuvant chemotherapy is the first line of management in this kind of scenario where there is a fixed tongue, there is a conglomerated or matted node on the ipsilateral side. There is a contralateral node. So these kind of tumors, the chances of operability is hardly 10 to 15%. So in these cases, first you give neoadjuvant chemotherapy, see the response after the chemotherapy 6 cycles or 4 cycles. Then after that, when you assess, then you see whether still the tumor is the response to the response of the nodes, the primary tumor size and everything. And from that you can know whether you can do a curative surgery or you can make the patient to go for definite chemoradiation and followed by palliative intent. And palliative intent can be further chemotherapy. But the first, in such a scenario where you have stage 4B disease, I think neoadjuvant chemotherapy is the first. Then you decide whether to go for, if the response is good, then do the surgery with a proper recon. This patient will need a free flap definite because midline crossed, floor of mouth involved, and bilateral neck to be addressed. So it is going to be very extensive surgery if the patient gets converted to a surgery. And otherwise, if they don't, then you give chemoradiation and send the patient to the palliative group. So you must make whenever you plan, you make the intent, curative intent, palliative intent, because patient always have a question whether I will get cured or not. So according to that, the patient will plan his family, he has social outings, he has child marriage, he has bank accounts to address. All these things the patient will plan. So from the very beginning, you have to know that how you are going to treat, and the planning is important to explain the prognosis and whether, and you very simply tell, we will stepwise approach and reassess at different points to give you where the patient is going to lead to.
Yes, sir.
Okay,
Any
Dr. Manisha.
other comments, please?
Yeah, I would just like to ask you, what are the factors in the patient which will tell you the patient has got a poor prognosis?
Sir, higher stage, sir. Or
Okay, tumor size more than 4 centimeters has a poorer prognosis.
yes, sir.
Then comes histologic grade, which you've not mentioned. So what you should mention moderately, right? So grading is also important. Depth
Yes.
of invasion, how much? More than? If it's more than 5 mm, there's 87% chance of patient getting not responding, relapsing. Okay.
Okay, sir.
Then, of course, is vascular and neurological involvement. So these are the factors which you have to take into account
Yes, sir.
in deciding whether, like Dr. Acharya said, palliation or curative. Anyone else? Rudra?
I think Mayank is there or left.
No, sir.
So, yeah, so you can have final few points because we are already 9:45.
I think that we have already discussed it in detail. So nothing much to add, sir.
Yeah. So
I would just like to make a comment on the PET scan, which is there. You know,
Okay,
why
sir.
the PET scan is not a standard of care, even in the 8th edition of the AJCC for any cancer. The reason is that there are a lot of the false positive results which are there, not because of cost or because of availability. It is mainly the false positive results which are there with the FDG PET scan, that you do not do it as a routine test. like a patient having a simple dental caries is there. That will also take the FDG uptake. And you will start thinking that probably this is because of metastasis. But that is not the metastasis. So that is why the PET scan is kept only when there's a recurrent disease is there or you want to follow up the patient for that, then you keep the PET scan as a standard of care. That is like in the breast cancer. We can do the PET scan and you need not require to have the CT abdomen and the CT thorax and all those things. But because it can pick like a simple tuberculosis is there, patient having the tuberculosis lung is there, which is so common in India that you will think it is a metastatic deposit is there. And that is why this is not taken as a standard of care still in the AJC guidelines. So that is my comment about the PET scan, which is there.
True,
Sir,
sir.
yeah.
Please.
I mentioned that in this patient only. See, the PET scan, I think now has come a long way, that the technology has advanced a lot. Now we have many new, earlier there was only FDG, now we have PAPI, we have many other molecules to do PET. So it has a good sensitivity, but in Indian setup, there are many issues. What you have mentioned is right. Plus, other thing I will just like to add, like in India, we have a lot of granulomatous diseases. So if we do a PET, many times we find medicinal nodes having uptake and we don't know what to do with them. So more than often, it confuses you to take a decision. But in a patient where there are specific indications for PET based on their symptomatology, or if you are planning a response CT to any treatment, like once you have given NSCT, many times you see both. One is anatomical response, like morphological response also, and what is once you give NSCT, there will be shrinkage of tumor, as well as there will be the uptake of the FDG will come down. That's what we call as morphological response. So that also needs to be assessed. So it has, it should be used judiciously. That's true.
But if these patients come to me, then before starting the neoadjuvant chemotherapy, I will definitely do a PET, and I will follow up with the PET to assess the response to neoadjuvant chemotherapy or chemoradiotherapy later on, because that is the only way you can know how the avidity is getting less and the functional or the morphological thing is getting less. So mostly it is used in highly locally advanced tumors, or there is impending chance of systemic metastasis. So these are the only two indications where PET-CT should be done. But as a standard NCCN protocol, it is not mentioned because from the beginning it should not be used. It should be used at a stage where you have established already that it is a stage 4B locally advanced oral cancer, where you will use a PET for subsequent analysis of post-therapy response, and there is a clear-cut RECIST score where the scoring is done to know the previous, and the tumor grading is done, how it decreases imaging-wise in the PET-CT. When you do the scoring, you can know disease progression, or disease is stable, or disease is very good complete response or partial response. All these can be known in a sequential PET-CT when you give the start the neoadjuvant chemotherapy. So definitely this patient needs a PET-CT before starting the neoadjuvant chemotherapy. Although for Manisha this is little higher, but indication of PET-CT is highly locally advanced tumors or impending systemic metastasis, where you think that these type of tumors during the treatment also they fail and they result in a distant metastasis. So these are the two groups where PET-CT is done.
I think I stand to be corrected here that probably still this patient is in the stage 4A, T4A. It is not T4B because still the base of the skull is not involved. The pterygoids are not involved. The carotids are not involved. It is only the local extension of the tumor is there. So still it is T4.
No, because I think Umang told because it is going to the opposite side node actually.
No,
It has
node
gone to
doesn't
the
mean
opposite.
T4.
Yeah.
I'm asking the T4A and T4B. जो है.
Yeah.
Okay. So it is still a
Yes, sir.
T4A lesion is there.
No.
And
It is
though it is the
T4A
N3,
lesion, yeah.
it is N3 is there because the 6 centimeter node which is there, definitely it is the with the periodontitis which is there. So it is the N3 is there, but the T lesion is still probably T4A is there. And still, I think in this patient, the Karnofsky is very good. Somehow, this patient by looking at the face of this patient, he is maintaining a very good Karnofsky. So it's almost on 90 to 100% is there. So maybe this patient may be benefited after going for the neoadjuvant chemotherapy, and then probably we can definitely go for a radical surgery, doing at least on the left side the commandos, on the right side we do at least supraomoid resection is done with the wide excision and flap repair.
Yes, sir. I completely agree that this patient is not this patient should be having a curative intent, and the patient should be addressed with neoadjuvant chemotherapy followed by assessment for surgery. You might do a free flap because it is crossing the midline. You might get hardly 30% of the tongue, maybe 60-70% of tongue may be lost. So to have a good mobility and good swallowing function, you might need a free microvascular free flap. But this patient will be being curative intent post neoadjuvant chemotherapy. This patient will come in that 15% group where this will get converted to a operable oral cancer.
Right. Yeah.
Monisha, are you clear? Or
Yes, sir.
yeah, and you can now ask any questions you have in your mind to the examiners. Definitely, your examination is over. You have did very well. We because it was a single case. We extensively discussed almost 2 hours. So I think you after this you will not be having any confusion about oral cancer, but at least in a CA tongue. But still, if you have any questions in mind to ask to the examiners, you are most welcome.
Sir, for this patient, the the induration is crossing, sir. According to CT report, is also the lesion is crossing midline, sir. For this patient, what surgery we should do, sir?
So,
If it is operable after NACT.
yeah, what do you think? What surgery? Sir has told exactly what surgery to be done. Dr.
So
Khanna
wide
has already told.
excision with 1 centimeter, sir. Sir, when should we do partial glossectomy, sir, or a total glossectomy, sir?
I feel if you get a response to NACT, you may have to do a total glossectomy along with bilateral neck defects. So the problem with total glossectomy is multiple fold. Patient will have persistent aspiration, and sometimes to prevent that, you have to do further surgery, what we call as sometimes glottic hitch. Some people even go ahead and do a laryngectomy just to avoid the persistent aspiration. So if you are going to be very aggressive, that in this patient and patient respond well to chemotherapy, then probably it will be a total glossectomy or glossectomy with laryngectomy with bilateral neck dissection.
Okay, sir.
It will be very extensive surgery, but sometimes it depends on response also, because not just crossing the midline and getting floor of mouth involved is not what Dr. Khanna told is not a contraindication for surgery. So you can get away with a total glossectomy, or even if you have 2 centimeter of the posterior tongue, you can do an anterior completely free flap, rotate the free flap, and you can create a tongue. Even if you have only protruding movements, he can swallow some liquids. So definitely some kind of function can be restored. and definitely this case will be converted to an operative case, and that will depend on the response. And let us say the operability is around maybe for neoadjuvant. If it does not respond, then you can convert this patient into definite chemoradiation, because initial neoadjuvant chemotherapy is a systemic treatment. Then you have to do a locoregional treatment. Locoregional treatment can be surgery with neck dissection or chemoradiation to address the local part. And still, if you post chemoradiation, if you still it reduces to less, then that will be called as salvage surgery. Salvage surgery is also done post chemoradiation. So induction chemotherapy followed by chemoradiation, then salvage surgery. But all will depend on how the patient responds. Okay.
Okay, sir.
I think Kangabel sir, thank you very much. I think we are done with the case.
We are, I think, one of the longest discussions ever had in the postgraduate clinics, I think.
Actually, whenever there is a oral cancer, this is a very common cancer. And I think Dr. Saha is very good in history part, and oncology part, definitely Umang and myself, we compensated. So
thank you, sir. Thank you for joining in such a short notice. And I'm sure this will be one index case discussion for the PG clinics, which is so extensive. Primary care, the post-RT issues, difficult type of combinations, what could be done. And I think the biopsy techniques, everything was discussed in detail. We were just, in fact, discussing in the chat box, telling like whether we should have 2 cases or 1 cases. But I think this is more strenuous for the postgraduate to have it being grilled. I don't think any exams across the globe also will have a single case for 2 hours. But anyway, thank you, sir. Thank you for joining. And we will be also requesting your presence in the subsequent oncology cases whenever we can.
Definitely, sir. Definitely.
Yeah, that would be very nice. That would be very nice to see Rudra and Dr.
General surgery postgraduates to have a wider outlook. And
yeah, actually, this induces some of them to take up oncosurgery, actually.
100%, sir. That is more. That's the ideology of running these type of national clinics, taking all the faculty in one platform. So sharing the ideas, it becomes a huge national multidisciplinary meeting, in fact. So many thoughts are exchanged. So, but then we wish to take your help also in the future classes, sir.
Thank you very much. Thank you very much.
And thanks for your
contribution,
sir.
Thank you very much. Thanks.
Wish these students also get benefited. Monisha, do we have any questions, or we call it a close?
Sir, no, sir.
Thank you, Monisha. I think you should set your laptop in order. So please check what is wrong. Probably you don't have the
What I think is, in the Zoom setting, she has not allowed the sound and something is there. I think in the Zoom setting,
she got it all right, sir.
I think it's okay.
So with the permission of the faculty, senior faculty here, and thank you, Monisha, for kindly accepting to be a candidate to be examined by the national pool of examiners. And then we look forward for yet another week of postgraduate clinics, which happens all Fridays. So I quickly ask our own faculty, sir, 1 case or 2 cases, sir? You please have to tell us. This 2 weeks.
1 case.
So I think it's 1 case, 1 long and 1 short case. That would be the.
Okay. I get your point, sir. I understand 1 abdomen or 1 breast, and then we can have 1 short case.
Yeah, that is very nice, because short cases are also important, where we I think we give only half an hour.
Okay.
Short.
Okay. Yeah. Yes, sir.
Thank you,
sir. With the permission of the faculty, I call the session a close. And thanks once again, Dr. Monisha, for staying with us. Amit sir, special thanks to you. And Kanna sir, Rajiv sir, and other senior faculty here, Mayank sir. Rudra sir, thank you very much.
Thank you very much.
Thank you very much. Good night, everyone.
Good night. Thank you so much. Very well done, Manish.